My name is Cameron Corbin, and my proposal topic was weight discrimination against women in healthcare. I chose this topic because I have personal experience with these issues. I have talked about these shared experiences with friends and family, and I have noticed a lack of conversation about the issue, especially in the media. First, I would like to talk about the research that I've done and what I've found from academic sources. The first thing I would like to point out is that a study did find that implicit anti-fat bias is as common among doctors as it is among the general population, which is very high. I also did some research on why people become overweight or obese to point out that this is not just an issue of people's decisions, but it is an issue of genetics as well. Harvard Health found that up to 80% of someone's predisposition to being overweight can be accounted for by genetics. Harvard Health also suggested that genes may account for a higher percentage of this disposition if the person has been overweight for much of their life, one or both of their parents or several other blood relatives are significantly overweight, or if they cannot lose weight even when they increase their physical activity. Anti-fat bias is pervasive among medical students as well. One study found that 40% of medical students have a moderate to strong anti-fat bias. For comparison, the same study found that only 17% of medical students had a moderate to strong anti-thin bias. Another issue of discrimination that I found impacts overweight and obese women is blood pressure cuff size. Research has shown that using a cuff size too small for someone's arm can artificially increase blood pressure readings. This can lead to unnecessary blood pressure medications and related diagnoses. Weight discrimination increases as BMI increases, as this study found. People with BMIs in the range of 30 to 35 experience less discrimination than people with a BMI above 35. This issue impacts women differently than it does men. This study found that women start to experience weight discrimination at a BMI of 27, whereas men don't start to experience discrimination until a BMI of 35 or above. Another issue in the medical field regarding weight and women specifically is the morning after pill. Studies have shown that the effectiveness of Plan B on women weighing over 165 pounds may decrease. The European Union changed the label on these medications to warn of reduced efficacy. However, the FDA found this research inconclusive, so there has been no label change made in the US. 1 in 5 pregnant women, both including pre- and postpartum women, have experienced weight stigma in healthcare settings. I localized my topic by contacting organizations and individuals to speak on this issue. I did not find any organizations actively addressing this issue in Middle Tennessee. I reached out to a few activism organizations focusing on women's issues, however, I did not receive a response. So I focused on individuals for this part of my project. I spoke to 9 women and non-binary AFABs who experienced medical weight discrimination. 5 of them live in Murfreesboro, 1 lives in Nashville, and 3 are living in the Chattanooga area. The ages of these individuals range from 20 to 71. I found these sources through Facebook and through word of mouth. Among the experiences that people recounted to me, one of the most common was unwanted and inappropriate comments about their weight. One person told me about a doctor who asked their parent, "What have you been feeding your child?" This was in front of the child and extremely inappropriate. Another tried to address the child's weight by saying, "We need to talk about the elephant in the room." And another accused the patient of lying about their food consumption because of their current weight at that doctor's visit. The other major issue that these people talked about was doctors attributing all health concerns to weight. One person talked about a doctor who refused to check for a miscarriage when they went to the ER because they assumed that the bleeding was weight-related. This person is now possibly infertile from not catching the miscarriage early enough. Another was not tested for ovarian cysts despite asking for it and was recommended weight loss. That patient later had to surgically remove a cyst the size of a softball. Another patient was prescribed Xanax for nerves when they complained about side pain. They later found it was a severe kidney infection. Another patient had endometriosis symptoms and was ignored and recommended weight loss. They still have not been tested 5 years later, even though they have a family history of endometriosis. Another doctor tried to blame the patient's broken leg on being obese, even though the doctor already knew that the patient fell down concrete stairs. Another patient complained of chronic back pain to a doctor who recommended weight loss. The patient has now lost 60 pounds, however, the back pain has only worsened over that time. Another patient had degenerative disc disease and asked to be tested for it. Several doctors refused to test for it despite the patient asking, and that patient was later diagnosed by another doctor. Another patient complained of severe period cramps, and the doctor wanted the patient to wait 3 months for any testing while they lost weight, which was 3 more severely painful periods. I asked all of these people whether they thought these experiences were related to their sex or gender. Many said that they were not sure. However, most of the people interviewed believed they would have been treated better if they were a cisgendered man. 2 of the people I interviewed recounted comparisons between their care and the care of overweight and obese family members who were male. This is an important story to cover because the obese population is rising everywhere in the U.S., including Middle Tennessee, and everyone, despite obesity or being overweight, should have equal and thorough medical care. Another important reason to cover this story is the negative effects of weight discrimination. Perceived weight discrimination in one study was associated with significantly higher odds of diagnoses like diabetes, heart conditions, and stomach ulcers. This bias can affect clinical care and the doctor-patient relationship. It can also dissuade people from going to the doctor whatsoever. Many of the people I interviewed said that they do not go to the doctor or do not want to go to the doctor because of medical weight discrimination. And lastly, this is an important topic to cover because people's lives are on the line. Medical weight discrimination increases mortality risk by 60%. This is not accounted for by other health risks associated with obesity. These are my sources.